I've been at a few of the physician advisor national meetings, sort of like hospital medicine, probably now 20 years ago, sort of was this new burgeoning career path for primary care doctors, and it just took off, and now it's bigger than GI or something. Physician advisors are the most recent example of that. More and more hospitals want to have a physician who their job is to organize the appeals of denials and payers, but also change what happens in their hospital so that they get it right the first time and don't have to go into this appeals thing. Get them to write the right words in their note. Get them to see what is inpatient versus observation care. And they have a very difficult job. And like I mentioned before, approaching doctors and trying to find a nice way to say, I would have done it differently, or did you consider doing it differently, is very difficult. I think a physician advisor as a physician has a better shot at getting that conversation off to any type of fruitful start. But you, at the same time, you want to make sure that conversation is clinical, not personal, not picking on somebody, not name calling, not because I'm more senior to you, that means I'm right. I've done it longer, that means I'm right. That there's some other source of information, and we like to consider ourselves like a safe harbor, a neutral middle road, trying to describe in words and numbers what is sick, and sick enough for a hospital, sick enough to get this procedure, how long might they have to stay, how do you know when they're on track to discharge and doing well, and all of that stuff to help make decisions, but also for the physician advisor to help docs document it. Very often, when there's denials or conflicts, it's not that they're really disagreeing that this patient gasping for air needed to be in a hospital. It's 3 weeks later, looking at your chart notes, I can't tell what was going on and why you did what you did and what you tried to do and it didn't work, so that's why you're doing this. And I can't approve this because there's not enough there. And the docs rightfully don't want to be writing, pages and pages of notes on every patient. So with this group especially, we try to focus on, look at our clinical indications. That's telling you the key moving parts to identifying somebody who needs inpatient care. What did you try? What effect did it have? Why do you say they're not better? What outcome are you looking at? That sort of thing. And in the hospital, our recovery milestones are just as useful to extend somebody's stay and justify more stay as it is to justify readiness for discharge. So if they're not ambulatory, if they're not hemodynamically stable, we give you a very clear, brief direction on what to document so that it's clear to everybody. And I think that is something that the physician advisors have mixed success in getting those changes. Everybody's had mixed success in trying to get doctors to, write different or better notes. But we think that this is a good approach because it's clinical, it's very concrete, disease by disease. It could be brief, so it shouldn't be more work. In fact, it might be less work. And it's sort of direct. There's such big consequences from it. It's important enough.